Today's topic is lower back pain. We are going to follow the same diagnostic model, starting with probable diagnosis. What can be the probable diagnosis if a patient comes to you normally in an OPD with lower back pain? He can have vertebral dysfunction and musculoskeletal strain, spondylosis, which is also termed as degenerative osteoarthritis. What are the serious disorders which should not be missed? Are in cardiovascular, he can have abdominal aortic aneurysm or retroperitoneal hemorrhage if a patient is on anticoagulants. In cancers, he can have myeloma, metastasis, and pancreatic cancers. Some serious infections like osteomyelitis and epidural abscess. In immigrants, septic discitis. In immigrants, these infections are very common, and we have to suspect if a patient is acutely coming with back pain. There is septic discitis and TB and pelvic abscess. Then we have osteoporotic compression. What is the osteoporotic compression? Due to osteoporosis, the vertebral bodies and vertebrae becomes degenerative and become porous, and they get displaced, and they can cause compression. Then we have quadri equina compression. It is a very important diagnosis which should not be missed, and it is a very it is a very acute emergency. Then we have pitfalls like spondyloarthropathies, in which we have a seronegative arthritis like ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and bowel dysfunction, in which there is Crohn's disease and ulcerative colitis. Then we have the sacroiliac dysfunction, claudication, in which we have vascular claudication and neurogenic claudication, Paget's disease, prostatitis, and endometriosis. These are the common causes of, these are the pitfalls which often get ignored if a patient comes with lower back pain. Then, coming towards the masquerades list, among the seven masquerades, the patient can have depression and spinal dysfunction, and UTI can also present with lower back pain, especially in pregnant women. Then patient, what can be the patient trying, what the patient is trying to tell me? For example, the lifestyle, the posture, the job he is doing, which makes which leads to lower back pain, stress, and the patient can be malingering, convergent disorders. These are the disorders which we can suspect if we talk to patient and he has certain psychological signs and symptoms. So coming towards there are certain history points which can point towards certain diagnosis. For example, by the nature of pain, first of all, we have to do red flags. What are the red flags if a patient comes to you with lower back pain? There are many. For example, if a patient is more than 50 years or less than 20 years, history of cancer is there, because vertebral column is the very commonest site, is the very common site for metastasis. So if a patient has a history of any cancer, we have to look for the cause of lower back pain. And we have temperature, he has a fever, and the pain is severe at night, constant pain, and which is severe at night. The pain is associated with weight loss. Symptoms are also present in other symptoms as well, which can show the metastasis. And significant trauma is, there is a history of significant trauma, features of spondyloarthropathy, some history points. Neurological deficits are there, and there the patient has a history of IV drug abuse, which can point towards the infectious causes of lower back pain. The patient is on anticoagulants, which can lead to the bleeding and retroperitoneal hemorrhage. And if the patient is on steroids, osteoporosis can be there. If the lower back pain has not improved in 1 month on basic treatment, non conservative management, it is also a red flag. The quadra equina is a very important red flag. in which the symptoms can be subtle anesthesia, recent bladder dysfunction, or overflow incontinence, bowel and urinary incontinence, bilateral or progressive neurological deficit. These are the symptoms of cauda equina, which we should not ignore if a patient comes with lower back pain. Now looking at the nature of the pain, by nature of the pain of lower back, we can point towards we can suspect different types of disorders. For example, if the pain is aching and throbbing, we can say the pain can be inflammatory. If there is deep aching diffused pain, it can be of referred pain from dysmenorrhea. If there is superficial and steady diffuse pain, it can be local pain, muscular pain. If there is boring deep pain, it would be bone disease, like Page's disease and cancers. And if the pain is intense, it can be of reticular pain, for example in sciatica. How are we going to differentiate in the inflammatory and mechanical lower back pain? In the inflammatory pain, there would be some history of inflammatory disorder, and the onset of inflammatory back pain would be insidious, while in mechanical back pain, there would be some history of injury, and there can be previous episodes of backache. The pain would be aching and throbbing in inflammatory, while deep dull ache would be mechanical. There is morning severe stiffness in inflammatory back pain. On the other hand, in mechanical back pain, the stiffness would be moderate, but in inflammatory disorders, the morning stiffness is very severe in the morning. And as the day passes, this stiffness becomes better, and at the end of the day, it becomes severe again. And the inflammatory kind of pain increases with rest, while the mechanical pain, it relieves with rest. And inflammatory pain is increased at night and in early morning, while mechanical pain, it becomes severe at the end of the day and after activity. Some history points which are very important to diagnose certain disorders. For example, if the pain is continuous in day and night, it shows some severe underlying disorder. For example, neoplasia and infectious disorder. Pain is coming on walking. It can be in depressive or inflammatory disorder. Pain increases with activity and decreases with rest. It would be mechanical pain increases with rest and increases and associated with moderate decreases on moderate activity. It would be inflammatory pain. Pain is increasing on standing and walking, and it is relieved with sitting. It can be spondylolisthesis. And the calf pain, if the patient is having calf pain associated with back pain, and the calf pain travels proximally, and it is associated with walking, and it is ascending type of pain, we can say it is vascular claudication. On the other hand, if there is neurological claudication, the pain is in the buttock which descends on walking. The pain descends on walking, it is in neurological claudication, and it is due to spinal stenosis. While if the pain is ascending on walking, it would be vascular claudication. On physical examination, there are certain specific tests. For example, straight leg raising test. It is classic. It is a test of sciatica. If there is 20 to 60 degree of elevation, and this causes pain, it is termed as positive SLR. And there is another test called a slump test. It is a screening test for disc lesion, low back pain, which is extending into the leg. Some investigations, for example, plain X-rays. Some investigations on coming towards the investigation, plain X-rays are usually not recommended in acute back pain in the absence of red flags. If the red flags are there, we have to investigate through X-rays if indicated. But if the pain is acute and there is no red flag and the pain is of less than 6 weeks, we don't have to investigate through X-ray. Some important points in when dealing with back pain is that big primary malignancy in back in vertebral column is multiple myeloma, and big three metastases are from lung, breast, and prostate. Other three can be thyroid cancer, kidney cancer, and melanoma. If the young person comes to you and he has an inflammatory kind of pain, means that the patient has morning stiffness and the pain is increasing with rest and decreases on moderate activity. It is an inflammatory kind of pain, and he is a young person and he's coming to you with this complaint. We are going to suspect and investigate for ankylosing spondylitis, which is a seronegative arthritis. If there is one disc lesion, there would be one nerve root, except L5 and S1. One nerve root means one disc usually. Two or more nerve roots are if two or more nerve roots are involved, and the signs and symptoms are referring to two or more nerve roots, we are going to consider neoplasm and the metastasis. But if the one nerve root is involved, we usually think of the disc lesion. Okay, so we have a rule of thumb, which is if there is L2 to L3 disc is affected, the nerve root lesion would be of L3. If the L3 to L4 disc is affected, the nerve root lesion would be of L4. If the L5 to S1 disc is affected, the nerve root which is affected would be S1. Large disc, if there is large disc protrusion, it usually presents with bladder symptoms can be there if there is large disc protrusion. Retroperitoneal bleed can give intense nerve root signs and symptoms if the patient is on anticoagulants. So, if a patient comes to you with acute back and leg pain, we have to divide it into syndrome A, which is the surgical emergency, and it is usually of a spinal cord, in which we would have upper motor neuron symptoms, and if there is a cardiac venous syndrome, usually there would be lower motor neuron syndrome, lower motor neuron signs and symptoms. If, for example, if a patient has saddle anesthesia, which is involving the anus and the vaginal area, and distal anesthesia, loss of sphincter control, there is progressive weakness of legs and areflexia. This is a surgical emergency and we have to investigate it very urgently. Then we have syndrome B, which is probable surgical emergency. For example, paralyzing nerve root and large disc protrusion is there. It can cause the anesthesia and paresthesia of the leg. There is foot drop, motor weakness, absence of reflexes. This is probable surgical emergency, and the large disc is involved. Then we have syndrome C, which is disc disruption. Radicular pain in sciatica, dural stretch test is positive. Right now, we are going to do which is non radicular pain. Non radicular and non specific back pain can present in any age. Usually, there is a history of injury like heavy lifting and twisting. There would be pain like deep aching pain, which increases with activity and decreases on rest and warmth. Usually, we have to treat the patient with conservatively over the counter analgesics and as exercise and physiotherapy. Then coming towards radiculopathy, radiculopathy is actually nerve root compression from disc protrusion. Most common disorder is sciatica. When does the radiculopathy needs surgery? Absolute surgery in radiculopathy is indicated when there are bowel and bladder symptoms. There is progressive motor disturbance. And what are the relative indications if there is severe prolonged pain and conservative treatment has failed? Coming towards lumbar spondylosis, it is also considered as osteoarthritis or disc degeneration. The patient presents with stiffness of the lower back, and it can lead to spinal canal stenosis. Management is conservative, and the surgery is indicated if there is a history of stenosis and the patient is complaining of neurological claudication. Then we have a seronegative arthritis. Seronegative arthritis comprises of ankylosing spondylitis, psoriatic arthritis. Ankylosing and psoriatic arthritis. In these two disorders, vertebral column um, is affected along with girdle joints and ribs. Reactive arthritis mainly affects lumbar joints, and sacroiliac joints. And to diagnose seronegative arthritis in a patient with lower back pain, we have to look for some history points, which can be skin lesions of psoriasis, the history of diarrhea, urethral discharge, eye disorders, and other joints are also affected. So we will have to do the workup for seronegative arthritis. In malignant disease, there would be progressive neurological worsening signs, and there would be more than one nerve root affected. Um, First of all, if we are considering malignant disease, we have to exclude myeloma first. Then we have to search for six primary metastases. If there are sclerotic lesions in vertebral column, the cancers can be prostate cancer. The metastasis can be from prostate, breast cancer, and lung cancer. And sclerosis is also present in Paget's disease. If the lesions are of osteolytic nature, the malignancy can be melanoma, thyroid, and kidney. When we are going to refer the patient urgently, when there are caudate venous syndromes, severe radiculopathy is there, and with neurological symptoms, there are spinal fractures. These are the urgent referring points. And other referring points can be stenosis, spinal stenosis, neoplasia, and infection in vertebral column, and Paget's disease. So that pretty much sums up the lower back pain, how we are going to approach the patient with lower back pain, how we are going to investigate the patient, and what are the common disorders which often get ignored, and what are the serious disorders which we have to look for. That's it. Thank you.